Good morning, everybody. I believe two people, when they present, have challenge, or the most challenge: the early morning people and the end of session people. People are awaking or people are sleeping. So I hope we can keep everybody awake. In fact, I was supposed to present one case about atypical hypertensive disorders of pregnancy, or for the easy understanding, let's say hypertensive during pregnancy, intrapartum, or postpartum, let's say preeclampsia, an atypical eclampsia presentation. Let me ask a question. Who among you deal directly with a pregnant woman in the daily practice? Whether that's PHC, family medicine, hospital, whatever, Who among the audience deal regularly with pregnant women and would know that they are a complainer? And everybody, they have a bad reputation, pregnant women, that they complain a lot and they complain all the time. But actually, that's a very important key. When they complain, always take it serious until proved otherwise, not vice versa, right? Dealing with pregnant women, full of surprises all the time. Now, the first case is a lady who, 32 years old, primey lady, with a BMI of 26. She was diagnosed with 5 years history of type 2 diabetes. Outside pregnancy, she was well controlled with metformin. But during pregnancy, we had to introduce long-acting detamir. And with metformin, diet control, she was doing very well. Preconception, A1C was 6. And then during pregnancy, as I told you, now, this lady at 35 weeks of gestation presents to Latifa Hospital Emergency with a story of having sort of vague symptom. She had a vague abdominal pain, not really typical, like right quadrant or upper abdomen or epigastric. And then she had 2 episodes of semi-loose attacks of loose motion. And the story of being, for the past 2 weeks, bothered by the increasing lower limb edema, pitting edema. Her workup initially was okay. And after 2 days, actually, they called the medical team in the morning of the 3rd day, right? Because everything turned to be fine. She's okay. Blood pressure maintained well, ranging in systolic 116 by 120 over 88 millimeter of mercury here. Range of blood pressure, that's the maximum and the minimum I'm showing you here. But the lady had something vague of that vague abdominal pain and feeling unwell, and her persistent complaint was, why my lower limb edema is increasing, though her workup was fine. We had no proteinuria. She had no symptom. The diarrhea stopped. The abdominal pain improved by 80-90%. She was eating, drinking well. She was in really good condition the day 3 when I saw her in the morning. Having the fact that lower limb edema troubled her, عارفين لعب الفار في عبي, that is something you have when you deal with those ladies in a regular basis. Being primey, being diabetic, 35 weeks, having that complaint, unexplained pain which is there, and the progressive lower limb edema. I talked to her. She's a very intelligent lady. I said, Mona, listen, you're in our category at this gestational age, being primey and being diabetic and having this symptom, which is still, we didn't really finalize what's happening with you. I want you to stay with us for quite some time, for a few days, 1 day, 2 days, and I assure you, inshallah, we will find solution. I don't know whether I was having, that experience feeling sort of, or what comes with experience, something you cannot explain in words actually. But then what happened, day 3 was the same morning. I saw her in the morning. Something amazing happened in the evening. She didn't report to people unless the morning of the 4th day that she's been having sort of, feeling unwell. Like I haven't been sleeping well. I had to put my back a little bit raised. I had to, call the nurse once and telling her I'm not okay. And the nurse started a 2 liter of oxygen, though she was with normal saturation. And the hemodynamics were absolutely fine. But yet she said, just to help her. And that will take us to another story, why that nurse did not report to our physician that night what happened. Now, when I come day morning at 6 a.m., no, it was actually 7:05. I reach usually early, around 7 o'clock. I had the early morning while I was driving. Please come, we have patient room 2. Oh God, I know room 2, that's Mona. Now saturation is 88. Acutely dyspneic tachypneic, RR is 20, and please Deemah, come immediately the minute you arrive. It is Mona, she is Mona. I said, room 1 or room 2 Mona was, but it was room 2. It was Mona who's there, dyspneic tachypneic, sweating like anything, crepitation up to mid zones. And I said, oh my God, this is an acute pulmonary edema, please push her to the HDU. And the story now, we will talk about what happened later then. Now, This pro-BMP came as 1,300, and here echo bedside was normal in our ICU or HDU, let's say. Now, the second case, I have to present a case too. That was antepartum, and the second case is postpartum. I know I'm talking about two cases, but we're talking about the same context of atypical presentations. She's I don't want to say elderly, otherwise I will be geriatric. Anyway, 43 years old lady. She's para 6, okay, BMI 31, and they had no chronic medical illness of whatsoever. She's active lady, normal pregnancy, had an NVD at one of the private facilities. Day 4, she presents back to that same facility, telling them, I'm having a headache. Now, she told me, retrospectively speaking, she told me that it was around, 4 to 5 by scale of 10, by 10 of pain scale. And the minute they gave her in the emergency an IV paracetamol, she improved. And she was reassured and sent home within 1 hour. Now, the lady at home was still feeling unwell, and that headache is still coming. But now with Panadol, it's not improving 100%. There's still element of, feeling foggy and not well. And then on top of that, she said, before coming to us by almost a couple of days, she's a bit breathless, like نفسي ضيق. I'm not easy breathing, I'm not well. And her blood pressure on arrival to our emergency was 116 by 75. She was never hypertensive, had a normal vaginal delivery, a normal antenatal follow-up. Now, 24 hours of observation, her BP remained, again, the minimum, the maximum within that range, and she was a little bit bradycardic. The workup, ABC workup, was with a bit of raised transaminases. Albumin creatinine ratio 42 above 20 is positive. Normal full blood count, RFT, uric acid was fine. All right, and the chest X-ray was congested with a pro-BMP of 730. Bedside echo was normal. Now, those two ladies, one was pregnant and one is postpartum, and this was the scenario. Now, to complete the story of our postpartum lady, she was managed fully as preeclampsia with her magnesium sulfate, diuretic, and she was observed for 5 days, and by day 5, she was sent home well, asymptomatic. We followed her 2 weeks later in the clinic. She remained normotensive with complete recovery. And for the first case, she was delivered immediately, managed as preeclampsia, magnesium sulfate, diuretic, observation, and the BP remained, the maximum she scored was 138, the average 135, but by the time we reached day 5 and 6, the BP came down to 105 and 110, and that's her baseline, actually. If you talk to Mona, she tells you, I never saw 115, whether pregnant or non-pregnant. And that takes us to the thing that by day 5, 6, she improved back to her normal baseline, seen after 2 weeks in our medical clinic. She was in full recovery, and she recovered the acute insult. Now, the mounting evidence of talking about atypical preeclampsia, or atypical presentation of hypertensive disorders of pregnancy is a lot of literature, if you look into it, starting from the time Stella and Sabai in 2006 started to put the criteria of atypical, 1, 2, 3, 4, and those are too extreme. Either very subtle symptoms, and you have to really focus and analyze this, and then eventually they progress, or the extreme end of being so severe, reaching up to hemolytic uremic and HELP, and the hemolytic microangiopathies and so on. So talking about those two extreme presentations, should always keep in mind that we're still talking about this atypical presentation in pregnant or postpartum lady on those two extreme, and even an increasing literature about the first presentation in a normotensive lady with no proteinuria is eclampsia. The first presentation. Now, this is not the time where we talk about details of pathophysiology, but again, the capillary leak stands as the best case scenario here. What happens? A capillary leak in the lung, a capillary leak in the CNS, capillary leak in the subcutaneous tissue. That would stand as the most logical, physiological explanation to what happened in the setup of being normotensive and being normal with her cardiac functions. That would be standing there. Now, what I'm trying to say, if you deal with a pregnant lady, always deal with the worst case scenario, have always low threshold to anticipate, to look at the symptoms, give them time, wait for a day or two, and things will come to you. They will evolve eventually, right? And I think we open floor for discussions now, later, whatever you like.
Thank you very much, panel.